and completed anatomic pathology and neuropathology training at Brigham and Women's Hospital and Harvard Medical School. His clinical responsibilities include neuropathology, soft tissue pathology, and molecular diagnostics with specialization in the interpretation of next-generation sequencing results in brain tumors. His research interests focus on uncovering genomic signatures and novel biomarkers for CNS neoplasms and translating these into routine clinical care. Dr. Meredith is also a founding member of the Dana-Farber Harvard Cancer Center for CNS Lymphoma, for which he has participated in the design of several active clinical trials and generated numerous tumor models to investigate tumor biology and novel targeted therapies for these rare cancers. I will now turn it over to Dr. Meredith.
Hi, Dr. Meredith. I think you're on mute still.
Let's see if we can fix that. Can you hear me now?
Yep.
Perfect. Thanks so much. So I'd like to thank you all for that kind introduction and the opportunity to speak today on a couple of my very close interests. And while the idea of mesenchymal neoplasms of the CNS can encompass a wide array of tumor types, including some very recently described histomolecular entities, I really wanted to focus on things that were much more likely to be seen in contemporary practice. So as we've already gone over the learning objectives for this round, let's start with meningiomas. This is a topic that I think probably most everyone has already had extensive experience with, but it bears going into a bit of review given the topic. It's the most common primary brain tumor in adults and conversely the least common in children. And the median age at diagnosis is 66 years. And while there are a number of histologic subtypes of meningioma, most of them share some degree of cytologic features that include a syncytial arrangement of tumor cells with occasional whorl formation. Nuclear pseudo-inclusions are common, as are abundant eosinophilic cytoplasm and rounded to ovoid nuclei with fairly delicate chromatin. Immunohistochemical markers for these tumors usually will include positivity for EMA and somatostatin receptor 2A. And of note, there are rare examples where meningiomas may occur as primarily intraosseous lesions, and it's just kind of worth keeping that in the back of your mind if such is encountered in practice. So here's a broad overview of many of the different histologic subtypes of meningiomas. I just wanted to talk about a few of these in a little greater depth. The transitional subtype of meningioma, as pictured in the top left, has these very prominent whorled architectures, very aesthetically pleasing. The meningothelial subtypes, one we showed on the introductory slide, and has most of the characteristic features that we've seen, but a more nested architecture. The fibroblastic subtype of meningioma is shown here, which is comprised of fascicles, short fascicles of spindled cells that, to my eye, kind of almost looks like stacks of pancakes, if you will, in that you have these short stacks of spindle cells that are separated by blood vessels or parallel or perpendicular fascicles of tumor cells. It can be variably abundant collagen deposition, and this is one of the subtypes that can really, have some problems on frozen section when a fairly limited specimen is submitted by the surgeon. Entities such as solitary fibrous tumor and schwannomas even can be considered in the differential when a fairly limited specimen is being reviewed, and we'll go over this in a little more depth in upcoming slides. Secretory meningiomas have these very characteristic PAS positive eosinophilic secretions within them. They're fairly common on the skull base and have a characteristic mutational pattern that we'll talk about a little bit later in the talk. Pseumomatous meningiomas are characterized by an overwhelming preponderance of pseumomatous calcifications. It's a feature that can be seen in a variety of meningioma subtypes, pseumomatous calcifications that is, but in this particular histologic subtype, it's really dominated by a wealth of these calcifications. Angiomatous meningiomas, such as those pictured here, with an abundance of thick-walled hyalinized vessels, and microcystic meningiomas frequently co-occur. One can see tumor types that have histologic features of each frequently co-occurring in each tumor. There can also be examples where they're more purely microcystic or purely angiomatous. Of note, these tumors can occasionally be very closely resemble hemangioblastoma in histologic appearance, especially the microcystic subtype, with tumor cells that have variably abundant cleared to palely eosinophilic granular cytoplasm. This subtype can be notable for fairly pronounced nuclear atypia, similar to hemangioblastomas, and have a number of small caliber blood vessels and capillaries that course throughout it. On a molecular basis, these tumors tend to have multiple polysomies. We'll talk about that in a little bit, but several of these do tend to have co-occurring characteristic cytogenetic aberrations. And occasional tumors will have fairly pronounced metaplasias within them, such as this picture that's also taken from the recent WHO classification guide that shows dipacitic metaplasia. One can also see more pronounced osseous metaplasia that's distinct from pseudomatous calcifications. So these are all varieties of meningiomas that can co-occur and can occasionally cause some difficulty in recognition. Of note, I did want to cover a few histologic subtypes that have specific grading concerns for those. And these, for grade 2 morphologies, would include both chordoid and clear cell meningiomas. So on the left is depicting a chordoid meningioma in which there's a very prominent myxoid matrix within the background, interspersed amongst which are cords and strands of meningothelial cells, which cytologically are usually pretty convincing for meningothelial origin. Of note, a number of the higher grade meningiomas, both atypical and anaplastic, can occasionally have fairly varied morphologies in amongst them. So chordoid features may be seen in a more focal basis in higher grade meningiomas, sometimes similar with clear cell features. But for the specific subtype of chordoid or clear cell meningiomas, we're really considering tumors that have an overwhelming majority of the tumor showing these specific morphologies. Clear cell meningiomas are of particular interest, not only because they have a very characteristic histologic appearance, which includes cells with cleared out to pale eosinophilic granular cytoplasm, but also very striking, coarse, blocky collagen that really predominates the background of the tumor. And these tumors were originally described in individuals who had familial SMARCA1 deletions, and as a result, many family members within these cohorts had spinal meningiomas, usually multiple spinal meningiomas of clear cell morphology. Since then, there have been multiple reports showing that sporadic clear cell meningiomas are, can occur every bit as frequently as familial forms. But like the familial forms, they also have homozygous inactivation of SMARCA1. If one has a stain, an immunohistochemical stain in the lab for SMARCA1, it can be a very useful ancillary diagnostic test, just to simply show that there's loss of staining within the tumor cells. And you can see in this image that there's retention within background inflammatory and endothelial cell nuclei, just as you might expect for a tumor with other switch SNF member deficiencies such as INA1 or SMARCA4. And if one has a targeted panel that includes this gene on it, one could also do that to demonstrate inactivation as well. I'll just finally comment that occasional clear cell features can also pop up adjacent to cautery artifact, and the tumors with bona fide SMARCA1 deletions really show a homogeneous appearance, such as that's depicted in this middle panel. Moving on to the grade 3 morphologies within meningiomas, there are two again, papillary and rhabdoid morphologies. In the papillary example, such as is depicted on the left, one can see clear papillary features, including central fibrovascular cores to many regions within the tumor. There are occasionally fairly prominent anuclear perivascular zones that are characteristic of this tumor type, in addition to this sort of discohesive appearance in the background with a little micropapillae of tumor cells falling away from the main tumor mass. Rhabdoid meningiomas, just as the name suggests, have a preponderance of rhabdoid cells that compose the tumor mass and have a fairly prominent epithelioid cell morphology with dense eosinophilic inclusions that displace the nuclei eccentrically. And although not as strictly correlating to rhabdoid morphology as SMARCI1 and clear cell meningiomas, occasional rhabdoid meningiomas can show BAP1 loss by immunohistochemistry. These are frequently associated with those individuals that have a BAP1 germline tumor predisposition syndrome. So most of these tumor types will show higher grade histologic features irrespective of the histologic pattern, but if in the event that one encounters a tumor such as these or the grade 2 histologies that do not meet grade 2 or grade 3 grading criteria, otherwise one is allowed to make those grading adjustments on morphology. So speaking of the grading features, this is a summary of those. Not much has changed in the current 2021 WHO classification schema as from 2016. So the majority of meningiomas that one will encounter in practice will be grade 1 or benign. Even still, the recurrence risk can be up to 20% at long-term follow-up. And these tumors will have low mitotic counts, less than 4 per 10 high power fields, and very few or none of the criteria listed below. Grade 2 meningiomas, by contrast, they now have a much higher recurrence risk, and for most centers, this is the cutoff that will trigger adjuvant radiation therapy following surgical resection of these tumors. And the easiest way to upgrade a meningioma is with mitotic count, where it's between 4 and 20 per 10 high power fields. One can also grade a tumor as atypical if it has 3 or more of the following set of softer features that include increased cellularity, sheet-like growth, prominent nucleoli, small cell change, and or spontaneous necrosis. And I think most of the experienced neuropathologists on the call will agree that this is by far and away the most subjective of the grading rules and can be fairly difficult to achieve a high degree of inter-observer concordance. And so as a result, anecdotally, this is a set of features that I tend to rely on the least if the mitotic rate is below the 4 per 10 cutoff. Since we at our center ended up doing a lot of chromosomal studies on our meningiomas, and we've learned over time that those tumors that have fairly benign cytogenetics or those tumors that have only some atypical features below mitotic rate tend to have benign cytogenetic changes. So this isn't as helpful, at least for me in my practice. Other ways to get to grade 2 would include, of course, having one of the characteristic morphologies that we discussed earlier, clear cell or chordoid meningiomas, or brain invasion. And brain invasion can be occasionally fairly difficult to ascertain. So I wanted to show an image that I thought was a really good illustration of this. So at the bottom of the image depicted on this slide, you can see the meningioma here growing that's on the meningioma, the meningothelial surface, so it's kind of upside down. And then the reactive brain tissue is completely surrounding an island of tumor that has completely invaded within the brain in this section. So we really want to see something akin to this, or even a finger-like projection that's diving into the brain. We don't want to see a pushing border along the brain surface, or just tumor invasion along the perivascular space. Something along those lines is really what is required to make that that observation. And then finally, grade 3 anaplastic meningiomas are fairly uncommon. These are frankly malignant tumors that are highly aggressive locally and can occasionally spread distantly, have a very high recurrence risk, as you might imagine. And the only way to make this diagnosis is with a very high mitotic rate or with one of the rhabdoid or papillary histologic subtypes. So when thinking about immunohistochemical workup of meningiomas, I thought this was a good summary figure pictured from this study a few years ago in JNEM that shows the panel of stains that is commonly positive in meningiomas here on the left, solitary fibrous tumors in the middle, and schwannomas on the right. I think in most instances, this may not necessarily be a differential diagnosis. It's terribly difficult to resolve unless one is dealing with maybe a small spindly tumor type, but any number of these stains can certainly be very helpful. If one does not have somatostatin receptor 2A, which is a highly specific marker for meningothelial lineage tumors, EMA works very well, at least in this differential consideration. SFTs, as we'll discuss later, usually will stain positive for CD34. STAT6 obviously will mark the upregulation of that protein product due to the characteristic gene fusion event. And some of the more cellular examples of SFTs will lose CD34, so that can be a helpful adjunct stain. And then schwannomas obviously will mark with nerve sheath antigens. And just of a quick note, fibroblastic meningiomas, such as those that are particularly spindly, will not infrequently stain diffusely for S100. So it's an important caveat to keep in mind when planning your immunohistochemical workup. Using SOX10 and or one of the meningothelial stains will obviously help resolve that, but just be aware that that may crop up in practice. Anecdotally, I did want to mention that there are some occasional mesenchymal tumors that do show some nonspecific SSTR2 staining. So I would be careful when relying on that stain in isolation if there's something else that doesn't seem to fit very well with meningioma. We do occasionally see some of these fibroblastic type tumors that are CD34 positive that arise within the meninges of younger patients. And while these are poorly described, some of them can certainly be dead ringers for meningioma. So if something doesn't quite fit, just keep that in mind and maybe be prepared to pursue some ancillary testing. Higher grade tumors, especially anaplastic meningiomas, can occasionally lose antigens. Some tumors can be very focal or negative for EMA altogether. Similarly with malignant peripheral nerve sheath tumors, if that's a consideration in your differential. As I mentioned with clear cell meningiomas, there's a very tight genetic correlation for those tumors with SMARCA1 inactivation. So I really like to see that loss of SMARCA1 by immunohistochemistry if you have it in order to make that diagnosis. Similarly, as I mentioned, BAP1 loss can be associated with rhabdoid meningiomas, but it's certainly not present in all of them. So that is not something that is needed for the diagnosis, certainly. Lastly, since most of our field in neoplastic neuropathology is moving towards tight integration with molecular studies, I wanted to give an update on a lot of the molecular underpinnings of these tumors and just kind of give a sense for where we may be going in the future with regard to integrating some characteristic cytogenetic findings in the workup of meningiomas. So, as this figure shows, it was taken from the WHO book. We can see a lot of the common features that are present in meningiomas. So most notably, loss of 22q or inactivation of NF2 is by far and away the commonest genomic aberration in meningiomas and can be seen throughout all grades. These are most commonly seen in fibroblastic meningiomas, for example. And there's a host of other mutations that can be seen in other lower grade morphologies. KLF4 and TRAF7, for example, are mutated in secretory meningiomas. They do not have NF2 loss. Similarly, meningothelial meningiomas can have smoothened and AKT1 mutations as well in the absence of NF2. Looking at features that are more characteristic of grade 2 tumors, as we mentioned, SMARCA1 is characteristic of clear cell meningioma, but outside of that specific correlation, the next most common would be loss of P1. And just to remind everyone that the polysomy of 5 and 20 that I mentioned very briefly at the beginning of the talk is most commonly seen with angiomatous and microcystic meningiomas. So that can occasionally be helpful. It's certainly not a one-to-one correlation, but one can encounter those changes with that histologic subtype. Loss of 1P is probably one of the most prognostically significant changes, probably one of the earliest changes when a tumor undergoes transition from grade 1 to grade 2 behavior. There have been a number of studies looking at the prognostic value of this marker in isolation and its correlation with grade 2 behavior. Certainly correlates very nicely, but there are definitely other changes that one can see as meningiomas start to go bad. The general rule is just the acquisition of multiple chromosomal whole chromosome or whole arm gains and losses is fairly commonly seen. And then as tumors transition to grade 3, one can see mutational changes in the TERT promoter, just as in GBMs or oligodendrogliomas. Loss of BAP1, as we discussed, is present in a small subset of those rhabdoid meningiomas. And then the biggest indicator of grade 3 behavior is a single or 2 copy loss of 9P where CDKN2A and B live. So that's a very helpful indicator of aggressive behavior. And so there have been a few centers who have gone on to integrate these findings into more advanced integrated type grading and risk stratification schema. I just wanted to cover a couple here for the sake of time. But here was a study that was done at our own institution that investigated meningiomas based on their histologic WHO grading and looked at the cytogenetic changes as determined by chromosomal microarrays. So in this left half of this large oncoprint figure, these are all grade 1 tumors by histology. And one can see a variety of gains in red and losses in blue in each of these individual tumor types that are sorted vertically. And so on the left, these that have no changes whatsoever are most likely the secretory and meningothelial subtypes. And then we have some fibroblastic tumors that have NF2 deletions. All of these tumors with the chromosomal gains are usually the microcystic and angiomatous subtypes. And then there's also a subset that have fairly complex karyotypes, kind of non-overlapping series of changes except for 1P. And then looking at the group with grade 2 histologies, we see kind of a similar distribution, except there's fewer tumors that have quiet genomes and more that have more pervasive cytogenetic changes. And then finally on the right are the grade 3s, which show essentially similar findings as portions of the grade 2s. And so what the authors in this study were able to do was to do individual and covariate analysis, not only of all of the typical light microscopic grading criteria that I've covered earlier, but also those cytogenetic changes that seem to have the greatest prognostic significance. And those were integrated into this novel grading rubric that's indicated in this square box in the middle of the slide, where you can see that the more high-risk molecular changes were each worthy of a point in isolation, and then mitoses still had a significant input in this grading scheme, and that a grade 1, 2, or 3 could be achieved by summation of all of these features. And so the end result of this study was that the majority of grade 1 tumors that were grade 1 by histology remained grade 1 after integration. There were some that were upgraded. The majority of those tumors that showed some of the softer features that had only 2 of the atypical features that I showed earlier in the talk, most of those remained as grade 1. There were some that were upgraded. But interestingly, the grade 2 cohort kind of evenly split into grade 1, some stayed as grade 2, and some were upgraded to grade 3, which is perhaps not surprising given the wide range of mitotic activity that is allowed for the grade 2 subset of meningiomas. And then lastly, grade 3s mostly stayed grade 3s, but there were some that were downgraded. My point is not to turn this into a journal club, but I just wanted to indicate what the effects of integrating cytogenetic changes with traditional light microscopy can do for this tumor type. So just looking at how the survival data shook out with only using light microscopy grading, it was pretty good stratification against all of the different grades. Now looking at the integrated grades, performing integration with those cytogenetic changes, it looks like there's perhaps a little bit better stratification. But I think the take-home points are now when we dissect this a little bit further, when we look at all tumors that had WHO grade 1 histology, if they had more aggressive cytogenetic changes, they did more poorly. Whereas those tumors that had more aggressive histology, but very, very quiet or benign cytogenetics, those tumors shown here in the blue line were essentially had zero risk of progression at up to 12 years. So we can perhaps condense this a bit and just show that all of the integrated grade 1 tumors, so you're looking at those tumors that had high histologic grade, below cytogenetic grade, had very little risk of progression. Conversely, those tumors that looked very low grade under the microscope but had higher grade cytogenetic changes, these were the tumors that were going to progress. And so the end result of doing so was that the prediction error in this analysis showed that the WHO grading scheme did worse, higher scores worse in this analysis, and the integrated grade actually improved as time went on. So the question I think is going to be, what do we do with studies such as this, and what is a potential reasonable solution to integrate molecular features with traditional light microscopy when it comes to grading meningiomas? And this is a summary figure from a very similar study that was done by the Heidelberg group. And I think their proposed workflow is very reasonable. So if one is encountering one of these tumors that has intrinsically low risk genomic alterations, so things like angiomatous or microcystic tumors, secretory or pseudomonas, there's probably no need to do any further testing. Similarly, those tumors that have defined WHO grades such as clear cell, I don't think there's need to do any further once that subtype has been confirmed. And so then what do we do with the others? And I think that's going to be highly dependent upon the resources available at each center. I think it's entirely reasonable to do isolated 1P and 9P examination, whether that's by FISH or colorimetric in situ hybridization or some other testing. And for those who may have microarray technologies available, either methylation or traditional chromosomal microarray, that may be something that's more useful for tumors that are at risk of being higher grade than histology predicts. So food for thought. I think this is very much a part of the field that's in transition, and I just wanted to bring it up here to perhaps predict where we might be seeing this go as time progresses. So I wanted to take a brief break and just kind of discuss a couple of cases and get away from some of the molecular things for just a second. So this is a 58-year-old man who had a calcified frontal extra-axial mass shown here in the MRI scan on the left. You can see that it looks like it has some involvement of the meninges and dura, and perhaps there's some involvement of the overlying calvarium. Heterogeneous internal appearance, in addition to some calcifications that were seen on CT imaging. And this is the appearance on the right. So I'll just tell you that this was an actual case of mine when I was a trainee, and this was diagnosed as a meningioma at the time of frozen section. And you may be able to see why, even from this magnification, we see a fairly cellular, spindled cell population enter amongst, these large regions of immature woven bone. Some of the nuclei are rounded to kind of short spindled nuclei. Some have nucleoli. But in truth, this is an example of fibrous dysplasia. And the reason I wanted to show this was this can occasionally pop up as a mimic for some other things that one may encounter. And as I'm sure many of you all no doubt know, fibrous dysplasia can occur in both monostotic and polyostotic forms, the latter being associated with McCune-Albright syndrome. They're usually arise within the first 3 decades of life, but the craniofacial skeleton can be a site of involvement, and some patients may be even older than the typical patient presentation, such as this. These tumors are driven by hotspot activating GNAS mutations, and the characteristic histology is that is typically described elsewhere in the anatomy. The only caveat I'll say is that when arising in the skull, some of these fibrous dysplasia examples can show prominent cementoid bodies, so circular sort of laminated calcifications and bone fragments that may not be quite as apparent in the other examples of fibrous dysplasia that have more curvilinear fragments of woven bone. But even in this example, you'll notice that there's no obvious epithelioid osteoblastic rimming around these bone fragments, just as one would expect in forms of fibrous dysplasia elsewhere. And this is just an odd example that happened to protrude outside of the calvarium and involve the dura and impinge upon the brain. So it was especially difficult at the time of workup. Okay, here's another example of a 66-year-old woman. She has a history of breast cancer and a recently found frontal skull lesion. This is not an uncommon scenario. Frequently, lesions such as this will be concerning to the oncologist who's performing follow-up scans for patients with a variety of cancer types. And the question is this a metastatic deposit? And as you can see here, this is a section, through the calvarium that shows a thickened structure with a number of these kind of empty spaces admixed amongst the marrow spaces. And you can see on higher magnification that these are lined by flat endothelial cells. And if one were to do a vascular stain such as CD31 or 34 or ERG, one would see nice positivity lining each of these spaces. So this is just a characteristic example of a bone hemangioma, which frequently occur within the skull in vertebral bodies. And they look pretty much just like this, usually these very dilated, thin-walled vascular spaces with varying amounts of a kind of reactive fibroblastic stroma. But occasionally they can throw people off if one isn't expecting this diagnosis. All right. Now let's transition back and talk about solitary fibrous tumors. The clinical features of these tumors are very similar to those of meningioma. These are considerably more aggressive tumor types than meningiomas, really irrespective of histology. They can have a propensity for long-time recurrence and even distant metastasis. It's really a unique feature of this tumor type. And many of you may have examples of cases of individuals who've presented with bony lesions many decades after a presumptive meningioma diagnosis. And in truth, those were likely solitary fibrous tumors, which have now metastasized to distant bony structures. So it's a fairly unique clinical presentation of some of these tumors long after the fact. And as many of you no doubt know, they're characterized by this NAB2-STAT6 fusion product, which is the result of a paracentric inversion on 12q. And while a number of breakpoints have been described in both of these genes, other than effects on cellularity, there does not seem to be a significant prognostic association with the different fusion products. So histologically, most of these tumors in the CNS will have a more cellular appearance than perhaps the classic conventional SFT appearance, which is depicted here, that shows the spindle cell tumor cell morphology with abundant collagen deposition and a somewhat haphazard arrangement. The more cellular versions can appear almost more round cell in appearance with significantly less collagen deposition. They can even have a very pseudopapillary appearance due to the discohesion of tumor cells as they cycle more and more rapidly. And most tumor examples will have these very characteristic staghorn vessels, the thin-walled vessels that are somewhat angular and dilated. So those can all be helpful diagnostic clues. And of course, as we discussed earlier, immunohistochemically, these The tumors are usually positive for CD34 and STAT6. STAT6 is preferred and more specific if you have access to it. And I'll also mention that this is another tumor type that can show metaplastic adipocyte metaplasia and can occasionally be helpful if meningioma is not in the differential. The grading of SFTs has undergone a fair amount of revision since the 2016 WHO guidelines. Cellularity is no longer a criterion that is considered for prognostic evaluation. Instead, largely thanks to the work of Caterina Giannini and her colleagues, there's been significant work showing that the combined value of mitotic count, which has been standard for quite a while for this tumor type, but now adding the evaluation of the presence of necrosis really helps in providing a fairly well stratified 3-tier grading scheme for these tumor types. For those of you who are familiar with the soft tissue risk stratification scheme for SFTs, that is not what is being employed for leptomeningeal tumors. Whereas that grading scheme includes patient age and tumor size, those features do not seem to have prognostic significance for leptomeningeal tumor types. So that's not something that has been included in the current WHO. So SFTs are now considered as either conventional SFTs when they're grade 1 and have less than 5/10 mitotic figures and no necrosis. The malignant forms of solitary fibrous tumor are those that correlate with grade 2 and 3. So those have greater than 5/10 mitotic figures, just as in the soft tissue world. And those that additionally have necrosis will be considered grade 3. So that is now our updated grading scheme that I think much better encapsulates the biologic potential of these tumors. All right, so let's take a quick break, and I wanted to show you a virtual slide. So this was of, I believe this was from a 56-year-old man with a clival lesion. And it was T2 bright and looked like it was eroding through the clivus into adjacent structures. And so this was a piecemeal excision that was sent to us for evaluation. So you can see from low power that there are some regions that are more or less cellular. As we zoom in a little bit more, we can see that there's a fairly prominent myxoid matrix within this tumor, and fairly uniformly so. It looks like the tumor cells are arranged in these kind of vaguely lobular nested arrangement of cells in which the individual tumor cells show a fair amount of monomorphism. They have kind of an epithelioid appearance with cleared to palely eosinophilic cytoplasm. The nuclei are rounded and have fairly minimal atypia. We don't see any mitotic figures. And there's perhaps some hint of some vacuolation to these cells, but perhaps it's not the best formed. And there aren't any mitotic figures or necrosis within this tumor type. And so this can be an occasional case that crops up. We usually get a few of these a year, and they can cause some significant problems given the differential consideration. So as we're reviewing this, I just wanted to spend a little bit longer just kind of looking at this virtual slide. You can just kind of think to yourself, what would I like to do for an immunohistochemical workup on permanence? What might I consider within my differential diagnosis? And I think here, this is a pretty good overview. There's certainly, I think we've seen most of what the slide has to offer. So now if I go back to the show. The question usually comes up, is this a chondrosarcoma or chordoma? And in this anatomic location, that differentiation can be awfully difficult. Shown here examples of one of each, and I hope you can appreciate how similar they can appear. So before I give you the answer, let's go through both in a little more depth and revisit this case. So chondrosarcomas are malignant cartilage producing tumors. Usually they're invading through existing bony structures. Most of the times they're graded by degree of cellularity and atypia. Mitotic count, when present, is usually indicative of high grade or grade 3 behavior. IHC usually is not terribly helpful in these tumor types that can express S100 from time to time, but usually that is not sufficiently diagnostic in and of itself. While most tumors will show underlying mutations in IDH1 or IDH2 at the same codons we're used to in gliomas, usually the exact missense mutations are different. So trying to perform immunohistochemistry for IDH1 R132H, for example, is usually not fruitful. Similarly, if one has a pan IDH1/2 antibody, most of those will not capture the mutations that are present in these tumor types. Of note, the ones that occur in the skull base are notorious for showing extensive myxoid change. And while in other regions of the appendicular skeleton, for example, that's a hallmark of grade 2 histology, in this anatomic location, that is not the case. So in one particular seminal study that was performed at Mass General Hospital back in 1999, a cohort of over 200 patients showed that the 5 and 10-year local control rate for chondrosarcomas was almost 100%, where it was significantly lower for chordomas. This includes proton beam therapy. So, and most of these tumors had extensive myxoid change. So this is, considerably more indolent tumor than we might expect for a similar histology elsewhere in the skeleton. And that's just something to keep in mind. So even those tumors with pure myxoid histology are still grade 1. Chordomas, by contrast, have much more bubbly appearances. Many of you are no doubt familiar with. These are tumors of notochordal origin, and as such will stain for the notochord marker brachyury. They also stain for keratins pretty reliably, and can be a useful marker in the event that your lab doesn't have brachyury in distinguishing from chondrosarcoma. But somewhat similar to chondrosarcomas, chordomas have a fairly pronounced chondromyxoid matrix in the background. The tumor cells are epithelioid. Usually they're more extensively vacuolated and contain the so-called phycoliferous cells. They can have these nice lobules of tumor that are separated by fibrous stroma. But on the fragmented specimens that we frequently get in neuropathology, especially in and around the skull base, sometimes one isn't able to see that nice architectural detail. And as we discussed, these tumors are significantly more aggressive, and especially at the skull base anatomy, and chordomas are not graded as they are for chondrosarcomas, but as you might expect, tumors that are larger and in older patients tend to have worse outcomes. So just going back to this case, so this is an image from our virtual slide. This was in fact a chondrosarcoma. And so I think sometimes the distinguishing features based on H&E alone can be awfully difficult. I purposely chose this slide to be difficult to make that distinction. But as a general rule, chondrosarcomas tend to be a little bit more monomorphic. Chordomas in many instances have more significant nuclear pleomorphism and atypia. And many chondrosarcomas frequently have double nucleation or binucleation of tumor cells, which is somewhat more common in these tumor types, but certainly not something that you'd want to make the diagnosis on in and of itself. And just to wrap up, I wanted to show that there are a couple of different types of chordomas that may be worth keeping in mind. Again, because of our specialty, we occasionally get very small fragmented specimens, and it's not always easy to make these diagnoses without larger resection specimens. But dedifferentiated chordomas may every once in a while manifest in your practice. And these are tumors for which there's conventional chordoma histology immediately adjacent to high-grade frank sarcoma NOS, something that really doesn't have any of the structural or morphologic characteristics that chordoma usually exhibits. And the same is true with the staining profile. So with keratins or with brachyury or S100 or any number of the other stains that mark chordomas, the dedifferentiated component usually is negative for those and can be awfully difficult to diagnose without that adjacent component. And just to show that these tumors are highly aggressive in this study, the 5-year overall survival is, right around 20%. So highly aggressive malignancy, definitely worth keeping an eye out for should you run across this. And then by contrast, for those of you who have a pediatric population in your practice, it's worth keeping in mind that poorly differentiated chordomas may occasionally show up as well. These are not the same as dedifferentiated chordomas. They have a completely different molecular genesis. But this is a tumor that is highly associated with younger patients, those in children and young adults, the biggest study to date. The median age was about 11 years, and they can arise throughout the axial skeleton, but clivus and C-spine tended to be the more common locations. The morphology of these tumors can mimic some other kind of esoteric soft tissue entities. They have this fairly pronounced epithelioid or even rhabdoid morphology that can sometimes evoke reminiscence of a Langerhans cell histiocytosis or an epithelioid sarcoma even. But with immunohistochemical evaluation, these tumors usually stain like conventional chordomas. They retain brachyury expression very nicely. But these are tumors that are driven by INI1 loss. So just like epithelioid sarcoma, if one doesn't do the brachyury, this can be an occasional pitfall. So these tumors will usually show INI1 loss and brachyury co-expression, but otherwise have no other characteristic morphologic details that would suggest that this is a chordoma. Certainly no phycoliferous cells, for example. And these are highly aggressive malignancies. They're essentially death sentences and very rapidly fatal. So clinicians in the pediatric setting will usually get very, very interested in making sure that if you're encountering a chordoma, that it is not this variety. So with that, that's all that I had prepared to present. I'd be happy to take any questions at this time.
Thank you, Dr. Meredith. It was a very interesting talk, especially I was unaware of that kind of pediatric version of chordoma. I'm going to be looking out for it. At this time, we'll move into questions and answers. You may submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat box, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner. Once you've asked your question, please remute to avoid background noise.
Larry and Dr. Meredith, this is Dr. Drexler. So I have a question concerning the CDKN2A loss. So, I've been doing that on a lot of my meningiomas, and I've noticed a lot of times I'm getting an allelic or heterogeneous loss, but not a homozygous loss. And the literature on the heterozygous loss is a little bit muddy in terms of how it affects prognosis versus the homozygous loss. And I'm just wondering what your experience has been with that.
Yeah, absolutely. So in this, these slides will be circulated after this talk, I think, on the website. And that reference that I put for the kind of integrated analysis study does in fact look at that and segregate out the 1 versus 2 copy loss, and they're both indicative of very aggressive behavior. So we've kind of been treating them more or less the same. I think you feel less comfortable with the hemizygous loss, but I think it's going to show that they're probably equivalent in terms of prognostic significance.
There is a question from the chat box. It says, greetings from Uruguay. Interesting talk. Is there any cutoff of G2/G3 histologic types to designate a meningioma as a G2/G3? Example, is enough to call G3 meningioma in a meningioma that have 5 to 10% of clear chordoid, rhabdoid, or papillary histologic types, in otherwise grade 1 meningioma, meningothelial meningioma.
Yeah, I think this is a pertinent question, one that we've always kind of struggled with. It kind of comes up the same with large cell anaplastic morphology and medulloblastomas. And I we really want to make sure that it's the predominant morphologic component in the tumor. I think those that are bona fide clear cell usually show that morphology throughout the entire tumor. It seems to be a clonal process. The chordoid ones tend to be slightly more heterogeneous, and so if it's greater than 50% or so by rough estimate, I think that's sufficient.
There's another question from John Donahue. It's asking, is PAS staining in clear cell meningioma helpful?
It certainly does mark a lot of those clear cells. We've got an interesting study coming out on the basic biology of these tumors, and there is an upregulation of a lot of the glycogenic pathways in these tumor cells. I think in general, it's probably not as sufficient. If one really has that characteristic morphology that I showed in the image, I think you're on pretty solid footing. I've not seen something that looks like that so homogeneously turn out to be something else. But since we do have a SMARCA1 stain, I like to use it and justify its existence in our lab.
Next question is from Romain Carroll. Do you use a D240 immunohistochemistry for chordoma versus chondrosarcoma?
I do not. I don't see why it necessarily could not be used. If that's kind of the marker that you have available and it works, and that sounds okay. I think any kind of keratin is probably the most sensitive and specific relative to D240 though.
Next question from Mark Delbigio. Can you please comment on sensitivity to progestins and whether this can impact histology or growth?
That's a good question. I mean, we know that females tend to be more, they tend to have a higher rate of meningioma incidence, and it can certainly, cause tumor growth during pregnancy, for example. But other than that, I don't know too much else. It's not something, PR staining, for example, is not something that we do routinely here, due to the relatively non-specificity of the stain.
Well, I think he's asking about whether progestins, if I get the question correct, like, things to regulate menstrual cycle, can they impact histology or growth?
With regard to histologic effects, I don't know the answer to that. I know that some women will notice, cessation of meningioma growth upon reaching menopause. So there seems to be a biological basis for that.
Okay, one more question. It says, do you have any insight on immunohistochemistry surrogates for CDKN2A co-deletion in meningioma, P16, or MTAP? That's something I want to know too.
Yeah, it's a good question. It's not something that we've looked at here, that I've seen done elsewhere. I don't see why it couldn't be done. Yeah, I think if a study were constructed properly and had good evidence of the molecular changes for the tumors, and you could correlate that tightly, I think that could be a reasonable surrogate measure. I'll also say that I think the majority of tumors that end up being grade 3 have a fairly high mitotic rate. I think a lot of the tumors that would be upgraded on the basis of CDKN2A deletion, this is just purely anecdotal, usually have an elevated mitotic rate that's in that kind of high end of the grade 2 category. Like it's very, very uncommon to have a tumor be upgraded from a grade 1 histology to a grade 3 integrated grade on the basis of CDKN2A deletion. So I think usually there are clues that it's probably likely to be borderline in the first place.
So you would not generally do the CDKN2A/B homozygous deletion on a typical grade 1, only those that are like looking like grade 2s transition to 3s, or
Yeah, I think prospectively, if one, at our center, we happen to profile all meningiomas. So it's, I mean, I know that's not common practice, but that kind of gives us a little more experience looking at the likelihood of these tumors to give us a surprise once the array results come back. And it seems like it's extremely uncommon for a grade 1 tumor to come back as a high grade when the cytogenetics return. I have seen a few, but it's extremely uncommon. So in general, I think, one usually has, like I said, histologic clues, and the ones that end up changing grade tend to be a little borderline anyway.
okay, I think that's, oh, one more question. Says from Mark Delbigio, do cytogenetic and methylation profiles correlate well in meningioma?
That's a great question. So if the question is, do the copy number profiles correlate? Yes, even though the copy number status is inferred from the methylation data, I think there are sufficient studies to show that they're pretty much pretty comparable. If the question is, do the methylation classes of meningiomas correlate with the copy number signatures, I think that's more opaque, and I think that's still something that we have to investigate further. I hope that answers the question.
Okay, doesn't seem to be any other questions other than a comment from Dr. Martinez-Laje. Thank you so much, Dr. Meredith. Excellent talk. And I say thank you to for everybody else. Very informative. Thank you.
Thank you so much for having me.
Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your Path LMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website within the next week. Thank you again to Dr. Meredith for an excellent presentation. This concludes the session for today.